this. Here you cannot go wrong. You can go for an anterior 3-level surgery, most likely. It's also quite successful. I had good, let's say, outcomes for both of them. But I think in this traumatic setting, a posterior cervical decompression is easier and perhaps a little bit more effective. It all depends on the characteristics of the patient. If you would like to discuss this a little bit more, depends on the anatomy. You know, what is the patient's anatomical, let's say, details. Is the patient obese? Is he young, old? Does he have any other prior surgeries? They have radiation. All of these things can make it an argument, depending on if you like to go for an anterior or posterior approach. In my mind, again.
Okay, so do you think that laminoplasty, it's something that Dr. Erliano Sufarnap is asking about, laminoplasty?
Yeah, laminoplasty. I think it's also a very good choice. I kind of moved away a little bit from these cases for different reasons, but it's something that we used to do in the past in our practice, and it worked very well also.
Yeah. I think probably we tend to do in my practice, we tend to do much more laminoplasty than laminectomy and fusions to try to avoid fusion. But in trauma, we still have a trend to go for fusion because sometimes it's kind of hyperlaxity of the ligaments that you don't really see on the MRI, and for trauma we tend to do more laminectomy and fusion, but for degenerative cases we tend to do more laminoplasty. Both are good options when we see the literature. So I think it's perfectly well to have it.
I think that you pretty much described the exact important differentiation. We had some patients that we did with a less invasive approach, but because of their, let's say, lifestyle, they will come back with more injuries. So a more definitive operation, I think it's a little bit safer for everyone. So that's why we moved a little bit away from a laminoplasty option.
Yeah. Okay, so we have also the proposal here, the proposals here to do either laminectomy and fusion or laminoplasty. Is there anyone who would propose for an anterior approach and multi-level ACDF or even carpectomy? Maybe you can put in the chat. I also feel that decompression for multi-level, and here we're talking about, of course we can do a 3-level ACDF, but probably also in my hands we gain more space with the posterior decompression than with a multi-level ACDF. But it's perfectly well. It's also an option to do an anterior anterior multi-level ACDF.
Yeah, I agree with you. Some of this is driven by some medical legal aspects. When you do a posterior decompression, you're almost certain that the spinal cord is not under further pressure. There's no residual compression if everything goes well. And the anterior cervical, unless you do a corpectomy, there's always some concern from time to time. For degenerative changes, I think it's wonderful, but for these patients, there's a small question. I have done it. I don't want to say that it's wrong, but that's my preference in the latest years.
Yeah, we have the proposal here from Dr. Nali Uvaraj saying, I would do C5C6 capectomy and fusion. As we said, this is an option, but I will tend not to favor this as well because it's still a long fusion if you use a structural graft or a cage. It's a long space for a fusion. Yeah, I think it's again, it's of course it's an option, but I don't feel that this is really the best surgery for this patient. But no matter, of course, it's an option. Okay,
That's wonderful.
so yeah, so maybe we move for next cases.
Let me just.
So I don't see Dr. Andrew here.
Um,
Andrew Fainos, I think, is not
No, sir,
there.
he's not here.
No? Okay. So
shall we?
said, sorry?
Shall we go for the other case from
Okay,
where?
yeah. So what we said about Andrew was going to present case. Which case was that?
Number 3.
Number 3.
I just presented this one. So
can you share case 3 or?
This was a 3.
This is. Okay. I think this was case 1, no?
Yeah, this is now we present case 3. This is a case 4. Is Andrew has he joined?
No. Can you?
Yeah, I can start with that case if you would like.
Okay, perfect. Okay.
See if I can do this.
And then we will have Dr. Pedro Aguiar presenting his case.
Okay, that's wonderful. Give me 1 second. Just get things prepared.
Yeah.
I'll share my screen.
Okay, perfect. Thank you.
All right. So this is from Dr. Ferreira, and we appreciate sending the case. It's about 63 years old gentleman. He has history of high blood pressure, bronchitis. He is not smoker. His BMI is 28 approximately. Has been having severe right lower extremity pain for 1 month with paresthesias and weakness, difficulty with standing and sitting, improving with rest. He's using pain medication, tramadol, he's using acetaminophen and a muscle relaxant. No inciting event. He now needs some assistance to walk. He is using an aid, and on his physical exam, he does have weakness of the dorsiflexion and the EHL, approximately 4 out of 5. He does have decreased sensation on the right foot, and he has positive straight leg raising at approximately 20 degrees. He has no significant change in his reflexes. It's the impression of an L4 radiculopathy. This is his MRI. Unfortunately, I don't see which level is this. I would assume that this is 4-5 for the purposes of this presentation. And let's see if I can go to the next level. And I would still say that this is 4-5. This is a bit more, I would say, informative in terms of the CT scan. There is, if I would assume that this is 4-5 level, there is a central and rightward disc herniation, in my opinion, that seems to be extended to the foramen. and there's suspicion of lateral recess stenosis. That's the best I can say here.
Okay. Can you go and move to the left and the right in the MRI, or doesn't the slide? Okay. Maybe, yeah. Maybe we can. Yeah. Okay.
So this is a.
Yeah, we can see the video now.
Yeah, this is what it plays.
Okay. So probably with the video we will see some different cuts in the actual as well.
Mm-hmm.
Let's see if we have it. Yeah. Now we have
Now we can see that. Wonderful.
the actual cuts. Going down 3, 4. And this is for 5. I think we see a lot of epidural fat, right?
Mm-hmm.
Which is compressing concentrically the thecal sac.
Yep, that's wonderful. All right, so yes, I think that there is what I would call epidural lipomatosis to some degree, and there is a right disc herniation at L45. Let me see if I can find the level a little bit more. That seems to be extending into the foramen, and if I saw the images a little bit earlier, well,
it looks more like a circumferential bulging, right? A diffuse bulging of the disc.
Yeah, but I think there's still some disc protrusion into the foramen over here.
Okay.
So that's much.
So maybe we can see the same. So this should be a video as well.
Yeah.
In the CT scan. Yeah.
So
as you said, there is a protrusion going more to the right foraminal.
Yeah. So so it seems that there is this protrusion that we identified earlier on the MRI. But what is quite interesting, there is also a bony foraminal stenosis at the right 4-5. So I think that there is dual pathology. There's a disc protrusion that has occurred at the presence of bony stenosis at L45 on the right. If we can go back, it seems that here there's no significant stenosis due to loss of the vertebral or the intervertebral disc height. So the distance between the pedicles is not that bad. Let me just see here.
Okay. So maybe we go for the questions.
Yeah. So the first consideration, the first question is how to manage this patient, let's say in a more conservative approach. Would weight loss be considered? What would be the significance of his BMI in the treatment of this patient, and how we would attempt to take care of this patient? And the second question, what will be the focus? Is it the L5 lateral recess, or a more extensive decompression of the thecal sac? These are very valid questions. I would be interested to see what the audience, what the participants would say for this patient. I'll tell you a little bit of my thoughts. If we go,
when we look at when you look at the MRI, I think it's quite impressive the amount of epidural fat that there is around the dura from L4 S1. And aligning to the question, there is also support from the literature saying that if those patients lose weight, and particularly if they lose body fat, sometimes the epidural fat, the amount of epidural fat also decreases. And in fact, we have some cases in our department like that, after losing weight, the MRI looks completely different. So this is maybe something just to think about. I'm not saying that it's the right solution for the case, but just saying that it is an opportunity.
Yes. Let me tell you about...
This is the proposal from Dr. Nali Uvaraj. Is saying for the amount of neurological deficit, he will go for immediate surgery as the claudication will not improve with the conservative management. That is his comment.
Yeah. While we're waiting for some more comments. Yes?
Or maybe you can share your thoughts and then we see if there are more comments in the meantime.
Yeah, we can say a few things. I think that this is one of the challenges that we face every day. What to do for a patient that presents with radiculopathy. He has some difficulties with stenosis. There are more than one pathology that can contribute to the patient's symptoms, and we have to understand what is the best approach for the patient. I can summarize for this patient that most of his problems are the radiculopathy from the right 4-5 disc. That's my feeling by reviewing the slides. He does have a degree of claudication, and that would be secondary to the stenosis from the epidural lipomatosis. So we either we have to address these issues or we can do expectant treatment. I think these two have a bit of a different treatment options and different goals. I think for the radiculopathy with some partial foot drop, I would tend to offer surgery sooner than later, just because of the weakness. Of course, other conservative options can be done and tried. For the epidural lipomatosis, this is a very big discussion in my practice when a patient comes with this diagnosis, with this imaging. There are papers, and I quote this to the patients, that early on recommend no surgery for these patients because they have other comorbidities, and the mortality rate is extremely high for patients with epidural lipomatosis. But in practice, we do operate on these patients, and they have a relatively good outcome. I always caution the patient of the possibility of recurrence of the epidural lipomatosis after surgery, and I give them the option of trying weight loss and see if this is going to give them the improvement without the surgery. Again, that's a very kind of controversial topic in my mind. I would tend to operate on a symptomatic patient, and the patient that has a body habitus like this, 28 in our practice is a relatively low BMI for my practice. So I would say that the chances of improving the lipomatosis may not be as great as the amount of weight loss that we would expect from this patient may not be as great, but it certainly can happen. If the patient comes with a very elevated BMI, sometimes I see patients with 42, 48, and the symptoms are not expressing, I would definitely recommend weight loss, bypass surgery or some sort of weight reduction treatment before we consider surgery. So these are the two big factors in my practice: the severity of the symptoms and the urgency of the operation, and the expectation of weight loss benefit down the road. And I also explain to these patients that although we can remove the epidural compression, this can unfortunately reaccumulate down the road. In my practice, the patients that I have operated, they did very well. It's still quite controversial, and I'm still cautioned about the recurrence. And I would be interested to see what is your experience and what would you think about a patient like that.
Yeah, thank you. If I may resume some of the comments from you and from me previously, and also from the chat here, I think particularly for younger surgeons and residents, which tend to be a lot in this forum, is that so epidural fat is really an entity that can compress the thecal sac. Opposite to bony compression, it can solve by itself, particularly if patients lose body weight. And so it's always it's important to have this discussion with the patient, that from one side this may improve without a surgery if they lose fat. On the other side, this can come back even if you do a good decompression, like Dr. Dimopoulos was saying, is that even when you take out the epidural fat, it can come back because fat can accumulate all over our and all over the body. And the other thing I would like to stress is that so this patient has a grade 4. So a grade 4 is not a major deficit. So a grade 4 is something that can recover without surgery. It's not a drop foot. So you have to discuss the options with your patient and try to define if one option, like was proposed there, was to do a smaller surgery to decompress the L5 nerve root, which seems to be, or L5 and L4 and L4, which seems to be the nerve roots that are causing the symptoms and the neurological deficits. And the other option could be to go more wide to decompress, to take out all the epidural fat. So it's important to discuss. There are many ways to skin a cat, and you have to decide to discuss pros and cons with your patient.
I think that's absolutely right. I think patient we have to understand what are the advantages and disadvantages of each approach, and what to expect in the future with either options, and that has an input on his treatment. For this patient, there's a couple of ways in my practice. It would be a minimal invasive hemilaminotomy and discectomy. That's something that will address both pathologies, the foraminal disc and the lateral recessed stenosis. I think that the foraminal disc seems to be the most important problem in my mind, and lately I've addressed this with the option of an endoscopic foraminotomy that also can be very helpful, and a discectomy, or a tubular. That's I think also quite viable. If I tend to do a hemilaminotomy, it depends on what is the side, let's say the elements of compression. I would ask the patient for a consent to do a ipsicontralateral decompression during the surgery. I don't do any open decompressions for most of my patients, and this could address a lot of the pathology in the same time with no significant increase in the amount of surgery. So perhaps a tubular hemilaminotomy with the potential of decompression during the surgery would solve a lot of the problems without a lot of headaches in the future, in my opinion.
Okay, thank you. So this is also the opinion of Dr. Sevlin Ethetias. She's saying she would consider to do partial discectomy on the right and foraminotomy based on patient's complaint. and not do anything for the epidural lipomatosis on the thecal sac. We'll try to modify the comorbidities first. So I think this is wise, and so I think we can move. We have about 10 minutes for last case, so we'll let Doctor, as you know, from now and this year, we'll have in each session, the board will choose the case that seems more interesting, and will you allow the author of the case to present live? So Pedro, please go on.
Hello everyone. So this is can you see my screen? I think so, right?
Yes.
All right, so this is a relatively young lady, 64-year-old patient. She had a 10-year history of breast cancer, which was under remission until 2021, and then she had a recurrence of the disease, and she needed to undergo again chemotherapy, and again she's under remission, and the cancer is relatively under control for the moment. She presented to our outpatient department with back pain that started already in 2021. She had an antalgic position and walking, and she presented also with pain on the anterolateral surface of the right thigh. Additionally, she presented with neurogenic claudication starting after 10 minutes of walking and bilateral lower limb weakness. Her pain has steadily gotten worse since 2021, and her main symptoms and what she feels is bothering her the most are the dorsal and the low back pain. And she has given both to the low back and the lower limb pain a VAS of 8 out of 10 under normal circumstances. And she was already proposed to have surgery 2 years ago, but with the recurrence of her breast disease, the focus was on controlling the oncological problem. And now that this is under control, the focus has again changed to the neurosurgical problem. She thinks, and she complains that the symptoms are highly debilitating, and she reports a very bad quality of life due to these symptoms. She has undergone basically all types of conservative management, and she didn't have so far any meaningful improvement. Regarding the neurological examination, she reports she displays no strength or sensation alterations in the upper limbs, but she has a proximal bilateral lower limb strength grade of 4 out of 5, and she has a bilateral foot dorsiflexion grade 3 out of 5. She also reports global hypoesthesia of the lower limbs and bilateral foot dysesthesia. No further relevant findings were found on the neurological examination, so I shall proceed now to the imaging. So, as we can see, there's a quite fast progression of her deformity in a relatively short period. In 2 years, she's unbalanced both on the coronal and on the sagittal plane, which has rapidly gotten worse in the past 2 years. She has a very positive SVA plus 17 centimeters, and also a C7VL is 2.5 centimeters to the left of the CSVL. Additionally, as you can see quite clearly, and you can see also that it has gotten worse, she has a L2 to L5 dextroconvex scoliosis with an angle of 45 degrees, and a T12 to L2 level scoliosis also with a 45-degree angle. Regarding the MRI, she has, I did not make a video, unfortunately. I didn't think about that. I could have done that. So I just took pictures of the 2 places where I found the most compression, which were at L2, L3 left lateral recess, and most importantly also at the L4, L5 level, where you can also see considerable compression at this level. So my questions for the board are these 3. So first of all, I don't know if you want to ask one by one, or I can present the 3 and then you all discuss. if you think this is a surgical candidate, what would be your surgical strategy? And secondly, given the fast progression of the deformity within 2 years in a relatively young woman, do you consider conservative approach as a valid alternative? And thirdly, and lastly, do you think decompression to treat only the leg pain is a valid approach in the patient that has who also complains a lot about back pain and has this deformity? Thank you.
Thank you, Pedro. But the patient also has neurological deficit, right?
Yeah, as well.
Pain.
Yes. No. She has.
She has a bilateral L5 dorsiflexion grade 3, right? So she has a neurology. She has a neurology on top of pain. So this patient has a sagittal and coronal imbalance. She has pain, back pain and leg pain, and she has a distal neurological deficit, right?
Exactly. She's got all of that. Yeah.
Okay.
So,
okay.
Hard not to operate.
Okay. Yeah. I think that's really. I think it's more. Yes, probably conservative approach is something difficult to support because she's progressing and she's getting worse. And of course, we can always have an option to operate or not, but it's hard to say that any kind we can do conservatively will improve her. So maybe we start hearing Dr. Dimopoulos' comments.
Yeah, I think that all the comments and the questions are quite valid. I agree with you, Dr. Pereira, regarding the approach. I think that you see a patient that is relatively young and is losing some of the function in the distal legs, also has significant axial back pain, as far as I understand. So it's important as a first step in my practice for these patients to identify what is the etiology of the problem, what is the etiology of the symptoms, and try to understand what to treat first. So if we know for sure that there's some radiculopathy, most likely from the lower levels, that affect the distal legs. So I think this has to be addressed. The second part is that there's some degree of axial back pain, and you have to identify what is causing this pain and how much debilitating is for the patient. What is the patient willing to sacrifice to get better? I would see a little bit more the status of the foramina. I think that when you see the AP views, you see on the coronal plane there is some what we call a fractional curve. So that means that there's some compression of the neuroforamina, in my mind, in the lower part of the spine, and I would definitely address this first. The second thing is, I'm sorry, I would like to see what are the parameters of the patient. I'm sorry, I have the measurements in another computer, but I saw that there is some discrepancy. There's a spinopelvic mismatch in your patient. I didn't see the calibration, and I would have to go with your numbers for the SVA, but definitely there is almost a 41 degrees in my measurement mismatch. So that's a significant, I would say, concern for me that this patient has a sagittal imbalance issue also, besides the radiculopathy. So the next step I will do, I will just have to make some sort of planning. Is it a flexible deformity? Can be corrected with a relatively smaller operation, or would you need a very big, long, quite demanding surgery for the patient? And usually I order a CT scan of the spine, the lumbar spine, to see what would be the lordosis in the supine position, what to anticipate during the surgery for me to understand how much correction would the patient need. And I will need some more, like a flexion extension X-ray, something that will give me an understanding if there's also and instability on the top of what I think is stenosis and deformity. So having all these things together, let's assume that the patient has no change in the flexion extension and has some partial reduction in the supine position. I would then try to offer the patient something that would help its needs, his needs, or her needs. I'm not sure it's a female. A traditional approach in my practice would be a quite extensive decompression. I'm sorry, a quite extensive posterior instrumentation with osteotomies. I have moved a little bit away from that.
What kind of osteotomies?
Usually,
at what level?
Usually would be osteotomies in almost, most of the levels that seem to be ankylosed on the CT scan. Recently, I would try to do a more, let's say, focused surgery with a more MIS type of approach. So nowadays, this patient will be an anterior approach, like an A-leaf at L5-S1 with a hyperlordotic case, with also an attempt for an A-leaf at L4-5 or lateral, at least L4-5, L3-4, and potentially L2-3. I would then repeat the standing X-rays and see how much correction we have achieved, and then plan for the posterior stabilization. I would prefer, if I could stay below L2, to do percutaneous screws and perhaps some MIS osteotomies, just to stabilize the spine and hopefully improve most of the sagittal balance and improve the quality of life for the patient, with the understanding that she may need to have an extension. If this seems to be not enough, I would consider a more extensive posterior approach, open approach with extension to the thoracic spine, something in the range of T9 or T10, depending on what's the apex of the curve in the thoracic spine. These are my my thoughts about this patient. I will always try to prevent or to preserve some of the motion and avoid the thoracolumbar arthrodesis as a first operation. Patients with this mismatch usually tend to make you think of this type of approach. But if the supine CT scan shows some flexibility and some correction, I would definitely try the anterior approach first, and then pretty much make a decision about a long or a short fusion. These are my thoughts about this.
Thank you, thank you. I think these are very important messages. One of them is that we really have to study these patients. On one hand, to do your measurements, to do your mathematics, let's say, to do how imbalanced these patients are from where to where. The other thing I also, in my opinion, is very important is what you mentioned about what is the patient's main complaint and what the patient really wants. So there is, for instance, a proposal from Dr. Boris Pavlov about doing only a decompression and endoscopic decompression at level 4-5. So again, in patients, there are always this kind of discussions in patients with degenerative scoliosis. For sure, there is a place for decompression only. There is a place for short fusion, and there is a place for long construct and for long surgery. It also depends on what's disturbing more the patient. So when you have a patient with a scoliosis like this, but has a drop foot on one side or radicular pain, sometimes it's good just to go there and do a foraminal decompression or a TLIF or whatsoever, decompress the nerve root, and that's all. So if the patient can live with the imbalance, with the deformity, and this is not what's causing the problem, definitely this can be an option. for a patient like this who has a positive valence of plus 17 centimeters and has a lot of back pain as well, it's difficult to imagine that the patient will have more than a short relief with a very small surgery. So probably I'll try to do all the measurement and again to try to stay as short as possible, but on the other hand, to try to do a surgery that is effective for the patient and not just improving for a few months. So this kind of balance is quite difficult because this patient, of course, has a lot of lordosis, but also has a thoracic kyphosis. So even this trend of going lateral, and we do more and more these kind of things, like lateral approaches on 2 or 3 levels, we can get like 30 degrees of lordosis. If you add an ALIF of at level of L5S1, you can easily get more 15 degrees or even 20 degrees of lordosis. And at the end, you can have like 40 degrees of lordosis just doing that and still staying at the level of L2. So sometimes this is really something that is useful for the patient. Is far less invasive than doing a multi-level osteotomy and a long construct. And the other thing that Dr. Dimopoulos just mentioned is that sometimes it's good for the patient to stage the surgery, to do one part of the surgery, to see how the patient behaves, how the x-rays look like, and then when you go back to you can also decide if you need to go longer or shorter. So again, tell the patient, see what the patient needs, see what the patient wants to get. Some of these patients, it's also they will not want you to operate on them if you are telling them that you're gonna do a construct from high thoracic to the sacrum or to the pelvis, that it's a big surgery with a rate of complication around 50 to 60%. So you have to discuss this with your patient and not just go there and put screws. That would be my message. Anything to add, Dr. Dimopoulos?
No, I think that's the most important thing. I spend a lot of time with the patient explaining what are the options and what will happen in the future, after the surgery, after 1 year or after 2 years, what to expect. And the patient at this stage of his life or her life will know what they want to do. And they will tell you, I'm not ready for the big one. I'm not ready for this. I would like to do this. And they will understand. I think it's very difficult, but it's very important to tailor the surgery that you're going to do, or the option of the surgery that you're going to offer to the patient's particular problem and needs. I think we see a lot of T10 to pelvis routine cases, and I don't know, I'm a little bit more conservative on these patients, and unfortunately, we cannot take the surgery back. We can put more surgery, but not remove the surgery. So I would favor a staged approach for these patients in my practice, and I think they're very grateful. They understand, and even if you give them 2 to 5 years of good quality of life without the limitations of a thoracolumbar arthrodesis, they're very grateful. They understand that, okay, 5 years from now, they may have to have an extension to the thoracic spine, or keep on having more and more problems with PJK and all other issues that we all know. But at least they can enjoy the life in the interim, and they can plan ahead.
Okay, so time is over for this session. Again, thank all the participants, all of you that joined here. So this is exactly the purpose of this spine board, is that we have informal discussion of our cases as we would do in our own departments. So it's not to select the cases that are very strange or very complicated. Some of them can see simple cases. Some of them are unsolved cases. So you can have, after a discussion in your department with different opinions, you can share with some of the experts all over the world that would give their own honest comment and input, not saying what's right or wrong, but again, the idea is to create a community of discussion or open discussion about for our cases. As you know, after April, that this will be for members only of the World Spinal Column Society. So we strongly suggest all of you to become members of the World Spinal Column Society. A lot of things are coming out with this society that you can see in our website as well. But until so next two sessions will still be open for everyone, February and March. Next session will be on February 18, only always Sunday, always this time, in different part this timing in different parts of the world. So please join, please submit your cases, please put your input and give your comments. It's very important to have your comments for these cases. We are not saying that we are right, just giving our input. And thank you very much, Dr. Dimopoulos, for participating, and Pedro for submitting the cases, and the other authors as well. Thank you very much.
Very much.
Bye-bye. See you on